My name is Charles Facelis, and I will be discussing hematology with you. Case 1 is a patient that presents with fatigue, jaundice, back pain, dark urine, and fever. A 30-year-old Greek man comes to the emergency department with complaints of an acute onset of fatigue, back pain, and lightheadedness. He also noted the onset of jaundice and dark urine over the past several hours. He had recently eaten at a Middle Eastern restaurant but states that he had no nausea or vomiting. He has no bright red blood per rectum or melena. He denies fever or chills. He states that in the past a physician told him that he has mild anemia. He recently had his gallbladder removed for recurrent gallstones. He's on no medications. So just from the history, there's a couple of clues to what's going on with this patient. He tells you that he developed icterus, jaundice, and not only that, that he's had a history of prior anemia, and recently he had his gallbladder removed. Now, this is a fairly young man, and you wonder, why would somebody get gallstones at a young age? Usually men don't get that, and you wonder maybe this type of gallstones were due to some hemolytic process. That's what you always wonder when you see recurrent gallstones in young people, especially men. And let's go further and take a look at the physical examination and the vitals. The vitals, he appears pale, and at the same time he's icteric and restless. The temperature is 101, the blood pressure 100/80, the pulse is 120 per minute. So he's pale. Right away, his hemoglobin is probably less than 9.5. By definition, when you develop pallor, your hemoglobin is less than 9.5. He's icteric, so he's got jaundice and he's got a low-grade fever. On physical examination, you confirm that he's got sclerotic icterus, he's tachycardic with a regular rhythm, there's no hepatosplenomegaly and no fecal occult blood. The hepatosplenomegaly and that there's no findings of liver tenderness is also important. In this guy, you always wonder about acute hepatitis, acute viral hepatitis, and this patient, the liver being non-tender, that is a very pertinent negative finding in this patient. So what's our differential diagnosis? Well, we still have to think about acute viral hepatitis. Acute viral hepatitis, like hepatitis A or B, may occur. It may occur with some association with some food or sexual contact. We don't have a history of anything like that here, but he may have eaten something that was contaminated. So acute hepatitis is a good possibility in this case. The only thing that doesn't go for that is the non-tender liver in this case. Acute hemolysis is a very good possibility in this case, especially when he says he's had a history of prior anemia, mild anemia, and he's had the gallstones, and all of a sudden now he develops icterus and low-grade fever and back pain. That's typical hemolytic anemia, especially with the dark urine. Now, hemolytic anemia can occur in 3-4 different types of hemolysis, 3-4 different types of categories of hemolytic anemias. There's a type called autoimmune hemolytic anemia. This is the typical antibody-induced, and there's really two types of this. One where the antibody directly lyses the red cells, and then another one where the antibodies hang on to the surface or click onto the surface of the red cell, and then this is removed by the reticuloendothelial system. Organs like the spleen remove these red cells. The typical ones that we see that are associated with autoimmune hemolytic anemia is mycoplasma. Mycoplasma, about 2 weeks after a mycoplasma infection, people develop cold agglutinins and antibodies against the red cells and develop the hemolysis. There's also types that occur that are secondary to medications, especially penicillin derivatives, alpha-methyl-dopa, and drugs like that, where you're taking the medication and a week or two later you develop antibodies and the hemolysis. So please remember, this is a very common cause of hemolytic anemia. Now, all these groups of diseases that we just talked about, the autoimmune hemolytic anemias, the characteristic thing about them is that they have antibodies. So when you check their Coombs test, it's always positive. The direct Coombs is always positive. The direct Coombs means that there's antibodies on the red blood cell surface. So you got to think about autoimmune hemolytic anemia, even though we have no history that the patient has taken any medication right now. We don't have a history of lung infection or upper respiratory tract infections, but we definitely have to think about it. Autoimmune hemolytic anemia is also associated with autoimmune diseases. So you may see it in the view of lupus and other autoimmune diseases. G6PD deficiency is a great possibility in this person. He fits the category. There's two types of G6PD deficiencies. The one that we most commonly see in this country is the type A, that we see of people of African descent. That's the mild type. And then there's type B, the more aggressive type, seen in the northern Mediterranean people. Greek descent, Turkish descent, Italian. So this guy fits that picture, and the history that he gives you of mild anemia before, and that he's had gallstones, fits that picture. Hereditary red blood cell membrane deficiencies and abnormalities like spherocytosis and so forth, or elliptocytosis, these are not uncommon diseases, especially spherocytosis is a possibility. But these patients get more of a chronic hemolytic anemia. They don't get acute on chronic or acute hemolysis. Really, these patients just basically have a defect in the cell membrane, and these cells get cleared sooner by the spleen and the reticuloendothelial system, so they have a chronic hemolysis. They develop gallstones, they have chronic anemia, but they really don't develop something acute, abrupt, like this patient came in with. That's usually seen in G6PD deficiency and autoimmune hemolytic anemia. So in this patient, I would have to think G6PD, really high on my list, and then autoimmune hemolysis, and less likely red cell membrane defects. Cholangitis, secondary to retained stone in the common bile duct, so the patient develops jaundice and fever, is a possibility, but much less likely in this patient. Doesn't look like he's septic, doesn't have the high-grade fever that cholangitis really causes, and of course, the most important thing is he doesn't have any pain on the physical exam when you palpate over the liver and the gallbladder. So right now, I would think about acute hemolysis due to G6PD deficiency or autoimmune hemolytic anemia as the first things on my list, then acute hepatitis, then I would think about that, and then last I would think about cholangitis, but I would want to rule that out because this is a serious disease, of course. So where do we go from here? Well, we got to get some lab studies to help us out here. So the complete blood count to assess the type of anemia in this patient and the level of anemia is very helpful, and to get a baseline in this patient to see where you started out from and if it gets any worse is very, very important. We're going to assume that if the exam is correct, that this guy's hemoglobin is decreased, because remember we saw the pallor. You want to look at the peripheral smear. Please remember, every time you find any type of hematologic problems, especially anemia, one of the most important things we have to look at is the peripheral smear. We forget to do that a lot of times. Please look at that. In this case, you would look for broken down cells, bite cells, and stuff like that that would point towards hemolysis. You also want to look at the PT and PTT. If you're concerned about rare forms of hemolysis like disseminated intravascular coagulation and so forth, then you want to rule that out, so you might as well get that too. You want to look at the liver function tests. because looking at the type of bilirubin elevation is very important here, right? So for example, with hemolytic syndromes, the indirect bilirubin is elevated. So that right away when you see that, that focuses your tests on getting things that look for hemolysis, for things like that, versus if you find direct bilirubinemia, then you look for things like acute hepatitis, obstruction from a stone, and so forth. So if they ask you in jaundice, what's the most important thing to look at first? They don't give us anything else, and they say, this guy's got jaundice, what do we look at first? The most important thing in jaundice is to look at the bilirubin through the liver function tests, because that kind of tailors your workup further. If it's direct, you look for liver disease and gallbladder disease. If it's indirect, then you look for hemolytic syndromes. In this case here, it will also help you if it's direct bilirubinemia. You're going to look at the transaminases. And if this is acute hepatitis, acute viral hepatitis, the transaminases are going to be very high, in the thousands sometimes with acute viral hepatitis, versus if the direct bilirubinemia is due to obstructive jaundice, then the transaminases are fairly normal or a little bit elevated, but then your alkaline phosphatase is elevated. Those are the obstructive enzymes, the obstructive picture. So please look at that. These are very, very helpful tests. A urine analysis will let you know if there's any bilirubin and things like that in the urine. An ultrasound of the abdomen, you may still be worried about the gallstones that we talked about before, so you want to rule it out. And then you got to get some other tests like the Coombs test that we're going to look at a little bit further down. But let's look at the results in these tests. The complete blood count shows white cells to be 5,000. That's pretty normal. The hemoglobin is definitely low at 6 grams, so the hematocrit is probably around 1820 or something like that. The platelets are probably okay. So the hemoglobin, very low here, very important. They don't give us the MCV here. The MCV would be helpful because usually with hemolytic processes, people kind of forget this, but with hemolysis, the MCV is actually a little bit elevated because of the reticulocytosis. If you have a healthy marrow and you break down peripheral cells, you put out a lot of reticulocytes, and this increases your MCV. So it's common with hemolysis to see an MCV of above 100, a little bit elevated. The peripheral smear shows bite cells present, so it looks like you're on the right track here. This sounds like a hemolytic process. The PT and the PTT is normal. The liver function tests show a very elevated bilirubin, 10. 90% of this is unconjugated, so indirect bilirubinemia, and then that tells you right away this is a hemolytic process, no doubt about it. The only thing that could cause indirect bilirubin of 10 is really a hemolytic process. The AST and ALT are normal, so you've ruled out the acute viral hepatitis. The alkaline phosphatase here, they didn't give it to us, but it's probably normal. We don't care about it because it's really the unconjugated bilirubin is elevated here, so we don't really we're not considering anything else except hemolysis here. The urine analysis is hemoglobin is positive, but otherwise is normal. And the ultrasound of the abdomen, of course, it's normal. You did it when you ordered everything, which is fine to get a test like this. But once you get back the liver test, you probably don't have to do the ultrasound. If you ordered it before, it's okay to rule out gallstones. But remember, gallstones in the common bile duct. Remember, this guy has his gallbladder taken out. But once you get the bilirubin back, that it's indirect, you should focus on hemolysis, not, retained stones and stuff like that. So a couple of other tests that we have to do that are very important. Urine for hemosiderin. Some people do this. It's really, in the acute setting, it's usually negative. It takes about 2 weeks with a hemolytic process to become positive. Now, with massive hemolysis, the hemoglobin in the urine, though, is positive sometimes. The haptoglobulin with an acute hemolytic process is consumed, so the haptoglobulin is low. And the G6PD level, activity level, be careful here. The G6PD level, because the G6PD really affects older cells, kind of like cells with 60 days and stuff like that, with older cells, the hemolyzed cells are gone already. And in the younger cells, the G6PD levels are usually within normal range. So it's common for people to get G6PD levels after a hemolytic crisis and to find them normal. And what you would do is wait about a month or two later and then measure G6PD levels again, and then you would find them low, because now you have aged cells within the population. So please be careful of this. They've asked a question a couple of times on the boards talking about what happens after somebody you think has G6PD. What happens to the level? The answer is, if you get it right away, because all the bad cells are dead, the G6PD level is normal. They tell you about this person from African descent, takes anti-malarials, they get a hemolytic syndrome, and you measure G6PD level, and it's normal. What does this guy have? The answer is he's got G6PD deficiency. The reason is because all the bad cells are dead and the new cells are alive. That's what he's got there. The hemoglobin of 6 are all new cells. They have good G6PD levels. So please remember this. And if you want to diagnose G6PD deficiency, measure it 1 to 2 months later. The Coombs test here is probably one of the most important tests here. If you're looking for hemolysis, if you've diagnosed a hemolytic syndrome, and we have in this patient, because we found bite cells in the peripheral smear, because we found indirect bilirubinemia with anemia and jaundice, we've diagnosed a hemolytic syndrome. The Coombs test here is one of the most important tests, because it tells you if you have autoimmune hemolysis versus non-autoimmune hemolysis. The non-autoimmune hemolysis is the G6PD deficiency, the membrane defects, and stuff like that. So please remember, this is very, very important test. It kind of guides you to what type of anemia, hemolytic anemia, you have here. A Coombs test that would be positive in this patient would tell us he's got one of these syndromes that I told you before, either mycoplasma-induced hemolysis, autoimmune hemolysis, or some kind of collagen vascular disease-induced hemolysis, or some kind of drug-induced autoimmune hemolysis like penicillin and alpha-methyl-dopa and things like that. So please always get the Coombs test when you're looking for autoimmune hemolysis and with any hemolytic syndrome, because it tells you what group of hemolysis you have. A Coombs test, the most important test to look at, is the direct Coombs. The direct Coombs measures antibodies on the red cell surface. That's the important one. The indirect Coombs is tells you that you have free-floating red blood cell antibodies. And free-floating antibodies doesn't mean they're on the surface. So you want to look at the direct Coombs, which means on the red cell surface. Some people look at indirect Coombs to let them know how severe the disease is, but for your purpose, look at the direct Coombs. That has to be positive. You have to find red blood cell antibodies on the surface. The crystal violet stain of the peripheral smear, some people do this to look for broken down cells. These are called Heinz bodies. You find them within other cells, and these are basically nucleated parts of nucleus, parts of other cells, so engulfed in other cells, and these are called Heinz bodies. So let's look at the results of these tests. So the urine for hemosiderin is positive, and I said to you, that's why it's not a great test right away. It's usually positive in a couple of weeks. It really needs about 2 weeks to be positive. The urine hemoglobin, though, is immediately positive. This turns positive right away if you have severe hemolysis. The haptoglobulin is absent. It's very low. It's consumed from the hemolytic process. The G6PD activity level is initially normal, but you know the concept here, so you know that if you repeat it 2 months later, now it shows the deficiency, and that's what you have to do. You have to repeat it 1 to 2 months later, and now you're going to see G6PD levels to be decreased. The Coombs test is negative because this is a autoimmune hemolytic process. And the crystal violet stain of peripheral smear, of course, shows the Heinz bodies. And let me show you the Heinz bodies, and you could see within the cell, those dots within the cells, that's basically just parts of other cells, nucleated material, and so forth. And what the Heinz bodies really tell you is that you've had some kind of hemolytic process. So we pretty much clinched the diagnosis here, right? We've said that even in the acute setting, even if your G6PD is normal, as long as your Coombs is negative, so we ruled out an autoimmune process. Now we think G6PD is on the top of our list, even if the G6PD levels are normal. Remember, you need your G6PD for oxidative stress. And if people don't have G6PD, have G6PD deficiency, with oxidative stress, you get a hemolytic process. What oxidative stress? Well, the most common one, oxidative stress, is viral syndromes. Anybody gets sick or a febrile syndrome, they tend to get hemolysis, especially with the older cells because they have the lower G6PD levels. Then the second most common is drugs, especially anti-malarial drugs. Be careful when you give anti-malarial drugs to people, because in people with G6PD deficiency, they cause hemolysis. Other drugs, like trimethoprim sulfa, are also associated with oxidative stress. And then there's some obscure foods that do it, like fava beans. So viral syndromes and febrile syndromes, medications, especially antimalarials, and then some foods. So those are the ones you tell the patients to avoid that have G6PD deficiency. So, but in this case, where do we go from here? He's got an acute hemolysis, and he's in our emergency room. So where do we go from here, our treatment plan? Well, in these cases, it's really supportive care. Supportive care. We manage them symptomatically. We hydrate them very well to prevent any renal complications from the hemoglobinuria. This is really rare that they get renal failure from hemoglobinuria, even if it's severe, because you really, it has to be really, really severe for that to happen. But you do hydrate the person well. You also consider transfusion support if necessary. If the hemoglobin drops further and the patient becomes especially symptomatic, has shortness of breath, dyspnea from the anemia, then you transfuse them. Young patients, they're usually able to tolerate even severe anemia, so most of the time you don't have to transfuse. Older patients, they have comorbidities. Even with a mild anemia, you have to transfuse them early than later. So the important thing here is to know is transfuse with symptoms. Or if the hemoglobin continues to go down, well, eventually the patient's going to get symptoms at some point or another. So you transfuse if it continues to go. It's dropping, every day. But generally, the goal here is to transfuse only when the patient has symptoms. And then, in the future, of course, you avoid the offending drugs or foods that we talked about, especially antimalarials, sulfa drugs, and so forth. So, case review. Acute hepatitis was a possibility in this patient. This patient would get jaundice really over a couple of days with a prodrome that we didn't see that this patient had. The patient would have fatigue and some of the malaise and symptoms that this patient had, but we didn't find the tender liver that we found that you usually see with acute hepatitis. And the clincher here, the definitive diagnosis, was made from the liver studies, right? We didn't find direct bilirubinemia, and we didn't find transaminase elevation. So we ruled that out. We didn't have to get any hepatitis titers. Autoimmune hemolytic anemia due to systemic disease like lupus, like chronic lymphocytic leukemia, mycoplasma, or drugs, especially penicillin derivatives. Please remember that. This is a common entity, and these patients present just like this patient with fatigue and elevated indirect bilirubin. Usually all the other liver enzymes are normal unless something else is going on, but the clincher here is that the Coombs is always positive. The direct Coombs is always positive. That's what diagnosis, that's the pathognomonic finding for autoimmune hemolytic anemia. If you were to find the Coombs positive, then you would look for one of these syndromes, the systemic disease from lupus, the mycoplasma, or the drugs. These diseases are usually treated with supportive care, just like we did with our patient, but in a lot of cases, these patients, because they have an autoimmune component to them, people tend to give steroids or cytotoxic agents, immune agents, and in refractory cases, you may need to give IV immune globulins, or even consider doing a splenectomy if this becomes a chronic issue. G6PD deficiency, what this patient had, we said, is due to acute oxidant stress, probably either from some type of food or medication or some kind of viral infection. Please remember, as I said before, there are two types of G6PD deficiency. The type A, that's the milder form that we see in this country mostly, that is usually associated with people of African descent, so Southern Mediterranean and African descent, versus the B type, which is more aggressive, and that occurs in Northern Mediterranean, Greek, Italian, Turkish descent, and so forth. So there's two different types. We see the more milder form in this country. That a lot of percent of people of African descent have this. And that's why you have to tell them, watch the medication, watch the antimalarials, and so forth. So the G6PD deficiency, the elevated indirect bilirubin, no bilirubin in the urine, the ALT and the liver enzymes are always normal except for the bilirubin. And of course, the clincher here is the negative Coombs test, the negative Coombs test that tells you this is non-autoimmune hemolysis. In the peripheral smear, you find broken down cells, and evidence of broken down cells like bite cells and Heinz bodies and so forth. Diagnose it, of course, by measuring G6PD levels, but remember always that the G6PD level could be normal initially, and then you have to measure it 2 months later to find it abnormal. Cholangitis and biliary obstruction was a consideration in this patient initially, but then we didn't think about it when we saw the liver enzymes. These patients present with jaundice, but always have liver tenderness, really high fever, and elevated direct bilirubin, really obstruction on ultrasound. We didn't have to do that in this case. Once you get the liver enzymes back and they show no evidence of direct bilirubinemia, you really don't have to worry about that. If you ever find cholangitis with obstruction in the common bile duct, the answer is you got to remove that, right? Either with an ERCP, treat the patient with antibiotics before for the cholangitis, but then eventually you have to remove the stone with ERCP. That concludes case 1.